to pressure injury imposters, avoiding skin injury, misidentification. And it is a problem. Too many things are being reported as pressure injuries that are not pressure injuries. We want to report it if it is a pressure injury, whether it be facility acquired or present on admission, we have to report them. But we only want to report pressure injuries that happen from pressure forces. So with that said, let's get going. First thing I have to do always is to read the disclaimer. This information is provided for informational purposes only. Patient care decisions should be based on relevant clinical guidelines, including current evidence-based literature, state and federal guidelines, such as from CMS, and facility protocols. I hope you have your policies and procedures related to wound prevention and management. Decision for wound management should be based on a holistic review of the patient's clinical condition. So you're looking at the whole patient and not just the hole in the patient. Your whole issues are going to fail if you don't look at everything. The clinical team members are encouraged to rely on their training and expertise, which is part of what you're doing here, getting some didactic education on this very difficult specialty in medicine, and this is wound medicine, as well as all available clinical and other pertinent information prior to making treatment decisions for any individual patient. So these are our objectives for today: to identify etiologies that look like but are not related to pressure forces, to describe the proposed etiology and appearance of chronic tissue injury, which we are reporting as pressure injuries. For the most part, a few people have this one, but not many. Verbalize the description of the unavoidable pressure injury, also known as the kidney terminal ulcer or skin failure, and discuss potential issues with misidentifying or misdiagnosing an etiology as pressure-related when the lesion is not related to pressure forces. So those are our objectives. These are your handouts. You have 6 of them, including a quiz. And one of the things that's important is if you get an F tag and you have to put in a plan of correction, there are many, many things in these 12 sessions that we're doing that will suffice as a plan of correction education module. And then you have a quiz to go with it to show the surveyors that you did your due diligence. So you can literally use some of these to help you with your plans of correction if you find that the surveyor faulted you on any of one of these 12 topics. So that's important, I think, helping you with your plans of corrections. You'll get this document also. So this is, when we talk about pressure injury imposters, it doesn't matter which care setting you're in. Across the continuum, acute care, outpatient, home health, long-term care, assisted living, this is happening across the continuum of care. Now, as you look at these 5 etiologies, these are 5 different etiologies on these bottoms. And I want you to look at where everybody's from. This is just wonderful. Thank you so much. Please look at this. Look at these 5 bottoms and tell me how many of these, honestly, tell me how many of these 5 bottoms are your people going to call a pressure injury? 1 of them, 3 of them, all 5 of them? Put the number in there that you think the people in your buildings are going to call pressure injuries. One person says 4. Somebody else. Do you have anything else to say? 1, 2, 3, 4, 5. How many of these are pressure injuries? We're going to keep going, but I'll be coming back to this. And you are going to get this document, Practice Dilemmas, Conditions that Mimic Pressure Ulcer Injuries, to be or not to be. And the reason there's an article like this and other articles that you're going to get is because this is such a problem. It's in the literature as a problem. Somebody else said 4. We're going to come back to this. So our introduction: the true incidence of pressure injury misdiagnosis is absolutely unknown. Absolutely unknown. We have no idea how many there are. There are many conditions that mimic pressure ulcer injuries. So the purpose of this program is to introduce one of the terms. One of those bottoms that you looked at was a chronic tissue injury, and to highlight other etiologies that mimic pressure-related damage but are not related to pressure forces. And lastly, the documents provided to support the conversations, these documents that we're giving you, they're to support your conversation with your clinical teams, including the providers. The providers get this wrong too. Your physicians, your nurse practitioners, your physician assistants, they get these diagnoses wrong also. And these can be used to educate your surveyors and even attorneys. I have attorneys that I teach this information to also. So why is this important? It's because pressure injuries and their associated tags and the wound characteristics that go along with pressure injuries have clinical, regulatory, which we're looking at survey at this particular instance, cost, reimbursement, and legal implications. And when we misidentify or diagnose an etiology, that can lead to, of course, inappropriate documentation. We have the wrong etiology. Mistakes in reporting the incorrect etiology to CMS, ineffective treatments for the etiology that we put in play, but that's not the treatment because we don't have the right etiology, inappropriate use of resources that we're using on the wrong etiology, issues with the survey process, and there can be complicating or negatively impacting issues related to legal defense when we get the etiology incorrect. So there was only one pressure injury on those 5 etiologies, and this was it. This is a deep tissue pressure injury that was over the sacrum in an mobility impaired resident, and you are going to need to, this is one that's present on admission, so you're going to document it as present on admission, a deep tissue pressure injury present on admission, and this thing is going to open into a stage 3 or stage 4. It's going to open into a full thickness wound. But this is present on admission. So when this opens into this full thickness wound, this is unavoidable in many instances. When a deep tissue pressure injury present on admission begins to declare itself, oftentimes it opens into a 3 or 4, and it's not the fault of the buildings if it came from another care setting. When we look you can't just look at F686 and think you're going to know everything about skin integrity that CMS wants you to know, because that's not true. F686 is for pressure injuries. It does mention a couple of other things, as does F684. So when you look in the top left corner, many of the presentations that I give, you'll find where this information comes from. And I do not ad lib on the state operations guidance to surveyors. I give you the language exactly. So with that said, in F684, which is our quality of life tag, there have 4, maybe 5 different etiologies that are mentioned. 3 of them are some of our most common etiologies that we get for wounds. They're arterial insufficiency wounds, or PAD, peripheral arterial disease, venous insufficiency that creates VLUs, venous leg ulcers, and the disease state of diabetes that creates DFUs, diabetic foot ulcers. So those 3 are mentioned in F684. In addition, the kidney terminal ulcer is mentioned for the first time, and moisture-associated skin damage might be. I can't remember there. So in F684, this is what it says verbatim. Residents may develop various types of skin ulceration. At the time of the assessment and diagnosis of a skin ulcer or wound, the clinician is expected to document the clinical basis. What's the underlying condition? What caused this wound to begin with? Well, it's a pressure injury. What caused the pressure injury? Well, they're immobile. What caused the immobility? That's how deep you drill to figure out what your etiology is. So what is the etiology that and in this case, it's going to be arterial insufficiency. That is the problem here. That is the etiology. That is the underlying condition that contributed to that ulceration. This is chronic venous insufficiency. This is diabetic neuropathic foot ulcer. So these are the etiologies. And then you're supposed to describe the condition. What do the ulcer edges look like? Are they attached or not attached? What about the wound bed, the location? Where is it anatomically? Is it the greater trochanter? Is it the ischial tuberosity? Is it the anterior iliac crest? Where is it? And you do your locations primarily by bony prominences, because that's where most pressure injuries are. If you're looking at pressure injuries, usually you're over a bony prominence, not always, but usually. What's the shape of the wound? Look over here, the top right, round, punched out. That's arterial. Just the shape gives you an idea of what the etiology may be. This one is irregular margins, and look at all the maceration around there. The irregular margins, wound margins, go more often with your venous leg ulcers, and then your diabetic neuropathic foot ulcers, which are usually kind of roundish over bony prominences. What's the condition of the peri-wound skin? Well, we probably have an infection in this arterial wound based on what we're looking at up here with all this erythema going way out outside that small hole. Here we have maceration in the peri-wound area. Here we have a callus around the peri-wound area. So the condition of the surrounding tissue should be documented according to CMS. And then CMS goes on to say, and this is such an important statement for you, CMS goes on to say, all of this stuff that you've just documented and recognized permits differentiating the ulcer, especially CMS says, if the ulcer has characteristics consistent with a pressure ulcer, It kind of looks like one, like those 4 other etiologies did on that previous slide, has characteristics consistent with a pressure ulcer, but is determined not to be one. CMS is asking us not to call things a pressure ulcer if it's not a pressure ulcer. So this is the definition and characteristics of chronic tissue injury. This is another document that's going to be provided for you. This is chronic tissue injury. That was one of the etiologies that we saw. And so we're going to have recognition and definition of what a chronic tissue injury is. How many of you think that you've seen this? Yes, number 2 was moisture-associated skin damage. Very good there, Bonnie. So how many of you have seen this and you think it has been reported as a pressure injury? It might be reported as something else. If you think it's been reported as something else, let me know. But how many of you have seen this, something similar to this? You've definitely seen this, Anya? Yes. Well, this is what it is. It is chronic tissue injury. So let's look at chronic tissue injury. I learned a new word when I started learning about chronic tissue injury, and that new word is lichenification. And I know it looks like chin, C-H-N, chinification. It's not. I had to go online and learn how to speak it, and you speak it lichenification, like Ken and Barbie, lichenification. So what lichenification is, you do see this for different reasons, but you will see it in chronic tissue injury. And one of the things you'll notice, let me see if I can do this for you. No, I can't do this for you. All right. They won't let me do this one. It won't let me expand it. When you look, I want you to look at these skin markings. This is this person's normal skin markings that are exaggerated. And that's what lichenification is. It's the normal skin markings that between inflammation, edema, some of the inflammatory processes that take place. This is lichenification with eczema. This is lichenification with scabies. This is lichenification with chronic tissue injury. So this is one of the things that you may see with chronic tissue injury. The other thing you're going to see with chronic tissue injury is going to be hemosiderosis. Hemosiderosis, a hemosiderin deposit. Think about chronic tissue, think about venous leg ulcers. Venous leg ulcers always, particularly if they've been there for a while, have hemosiderosis, that hemosiderin staining, that reddish brown staining on light-skinned individuals, darker skinned. It'll be a darker tone of their normal skin tone. You can still see the changes in color on dark skin. This is because the red blood cells, because of the inflammatory process that's taking place in this area, and it might be a watershed issue. We're still working with our anatomy and physiology on this. Nobody knows exactly why this is caused, but we are working on it. We have people that are thinking about it right now. That red blood cell has a life of 120 days. When it comes out of that vein, because the vein's inflamed for some reason, when it comes out, it deposits, it breaks down. The red blood cell breaks down. When it breaks down, it deposits the heme group. The heme group holds the iron, and that's what you're seeing, the iron deposit under the skin. That's your hemosiderosis from the iron that's in the heme group that's on the red blood cell. So that means there is a vein issue. When you see hemosiderosis, which is not bruising, this never changes. Your bruises, they always will go from a dark, like a bloody color, a dark color on a light colored individual, and then they might go to a dark blue, and then a green, and then a yellow. These stay hemosiderosis, reddish brown. This is not from pressure. This is from that extravastated red blood cells and inflammation. It's also affectionately called recliner butt. And it's seen in people that are in bed or chair bound a lot with limited mobility. And in Japan, it's called senile dermatosis. We don't have a real, we don't have an ICD-10 for this yet. I'm hoping it'll come. So why do we need all this information? We have no recognized label for chronic tissue injury at this time. You have to use, if you're going to use an ICD-10, you have to use your 98.8, I think is the one that you use. This may be misidentified as a pressure injury. Clinical teams may choose a wound type that most closely resembles this. Oftentimes, we choose pressure. So clinical teams may choose the wound type most closely resembling this tissue change when the tissue damage is not related to pressure. This results in inaccurate and inconsistent classification of that soft tissue damage. So it's either L98.8 or L98.9, which are disorders of the skin and subcutaneous tissue, unspecified. I can tell you it's not a pressure injury. Do not call it a pressure injury. Exactly what it is, we don't know, but it's not pressure. Always check with your coding experts to ensure the ICD-10 code that they want to use is correct. I am not a coding specialist. I'm telling you what other coders tell me they're using for this. So when we look at this, this is the same bottom over several months. This is January. Now, this is on the fleshy part of the buttocks. There's no pressures in this area. This person does have mobility. They do have incontinence. So one of the things that you're seeing here is you're seeing chronic tissue injury. This happened in January. Here it is 5 months later, May. All this stuff is done is moved around, and you do have a little bit of erosion. A little erosion here, a little erosion here. I promise you somebody's going to call this a stage 2 pressure injury, and that's not what it is. And part of it has to do with how mobile these people are. You don't get pressure injuries in people who are mobile. You just don't. So, and then here's October, another 5 months later, and nothing has really changed. Nothing is open. There's a little bit of erosion here, but nothing has erosion. And that's from the erosion is really from moisture-associated skin damage. So this is often called a stage 2 pressure injury. Can you see where that can happen, audience? Can you see where this would happen? Where someone would cause this a stage 2 pressure injury innocently. Innocently. They're not trying to call it something it's not. It's all the information they have. So can you see where somebody would call this a stage 2? I certainly can. So this is moisture-associated skin damage plus chronic tissue injury, but it was reported incorrectly as a stage 2 pressure injury. Whoops. All right. So here's in May. This is another one. Look at that deep purple here. Somebody's going to call that a deep tissue pressure injury for sure. This is in May. Here it is in October. And here it is a few months later. And no, maybe this is October. All you have here is this erosion from it's moisture-associated skin damage is what you have here. This is from the moisture and like sweating, moisture. It could be incontinence. This is not pressure. When you see that line down the middle of the gluteal cleft that's all the way at the bottom on the skin, and you get that breakdown, that's not a pressure injury when you see this. That has to do with MASD, and it may not even be incontinence. It could simply be that person sweating and they're in bed a lot. So that's what we have here, MASD plus erosion. This is in one of the articles that I gave you. And so how is your staff going to describe this? This is on one of the articles from the National Pressure Injury Advisory Panel. This is not a pressure injury. Again, this is your chronic tissue injury with erosion is what this is. And they're calling it a chronic friction injury. It's really all this purple that you see. It's chronic tissue injury. And then the friction is what caused the what looks like a partial thickness wound. This is a stage 1 pressure injury. Up here, both of these are stage 1, and a light-skinned individual and a darker-skinned individual. You can literally see the scratches there. That's called excoriation from the itching and burning that comes from inflammation. And then down here is your chronic tissue injury. So it's very easy to mix up a stage 1 versus a chronic tissue injury, particularly in a light-skinned individual. And if you don't have really good lighting, you're going to miss some of this in a darker-skinned individual. It's very important that we have good lighting when we're looking at dark skin. So this is, again, chronic tissue injury plus moisture-associated skin damage. Here is this one on the left, bottom left, was one of my patients that I was seeing that the family called us and we did some home health for them, and they said that they have a pressure injury. They have a stage 2 pressure injury. They didn't have a stage 2 pressure injury. They had chronic tissue injury. So this is, so when this up here on the top, this is a stage 2 pressure injury. This is a stage 2 pressure injury. This is not a stage 2 pressure injury. Can you see how difficult this can be? You really have to know what it is you're looking at. This has no, so these, if it's a stage 2, it's going to be partial thickness skin loss, which is, this is usually with a shallow open ulcer, which you see there. They don't have slough. Stage 2 doesn't have slough. This is epithelial islands. This isn't slough up here. There's no bruising. There's no purple maroon discoloration when you have a stage 2. These are usually over bony prominences. There's always going to be a mobility issue. You do not have pressure injuries without mobility issues. Now, if we're talking about wearing tight shoes that are too tight or something like that, that's different. I'm talking about pressure from immobility. You have pressure from immobility. These people with chronic tissue injury are usually not completely immobile. They may sit for a long period of time or be in the bed or the chair for a long period. So again, there's confusion between chronic tissue injury and stage 2 pressure injuries. And here's your deep tissue pressure injury versus a chronic tissue injury. And I think this one's the hardest, although the stage 2 is pretty difficult too. This is one of the hardest. Look at how diffuse this is over the buttocks, and look at how concentrated this is over the sacrum. Not only that, this is actually a little bit darker from bleeding than this is. Yes, this has red blood cells in it, but this is from bleeding from tissue damage at the top, and this is from the hemosiderosis where the red blood cells come out and put their iron, deposit their iron underneath. So deep tissue pressure injuries have this intense purple color discoloration of the skin. The discoloration of the deep tissue pressure injury appears deep violet, which refers back to that intense tissue load that we think causes the deep tissue pressure injury with the bleeding under the skin. And this deep tissue pressure injury, it follows a recognized course of deterioration where the deep tissue pressure injury demarcates itself, and then it will begin to solidify, and where you get your eschar oftentimes, or it may open and you end up with eschar and or slough, and you're going to end up with a full thickness wound. Whereas this chronic tissue injury, it lasts for months. This thing up here, it's going to be open in a week or two, maybe 3. And if it's on the heel and they have poor blood flow, it may be a month before it finally opens. This is going to go on for months and months and months and months. And pain, you might find pain with a deep tissue pressure injury. Oftentimes there is some pain, but not with a chronic tissue injury. Here it is again, and it's sometimes affectionately called recliner butt. So there's chronic tissue injury, purple room discoloration of that fleshy portion of the buttock over the fleshy portion of the buttocks. Now, I have seen it go beyond the fleshy part of the buttocks, and I'll show you a picture of that in just a minute. So often this is misidentified as a friction injury, MASD, venous engorgement, pressure injury, skin failure, and trauma. So we need more research. We need more consensus. We need more people reporting this correctly, but we don't have a reporting mechanism. That skin, that 98.8 or 98.9 that I just talked to you about, that ICD-10 code, this chronic tissue injury is going to get lost in it. We're never going to be able to count them. We have no place to count them through our EMR process. So these are the 2 codes that were suggested by coders, L98.8 and L98.9. Again, please check with your facility or corporate coding team. I do not claim to be a coding specialist. So other pressure injuries, imposters. Here is on the lateral malleolus. Someone was calling this a pressure injury, but when they went back and did their blood flow studies and looked at everything going on with this person, it's peripheral arterial disease. This is PAD. It was not a pressure injury. This is very interesting, and we've had one of these in our practice also. I work with a wound provider medicine group, wound medicine group that goes into long-term care and to home health. And we had something very similar to this. And the building was calling it a pressure injury, but when we finally got our vascular studies, it was an iliac artery compromise. And that's what this is. This is your iliac artery manifestation. So sometimes you'll see these bizarre things on the buttocks. And when they open up, that's not a pressure injury. That's not moisture-associated skin damage. It's iliac artery occlusion. And that happens sometimes also with severe peripheral arterial disease. And this was initially called a pressure injury also. This was initially called a pressure injury, and then it started acting really, really bizarre. And they finally got their all their information, and it's herpes is what it is. It's herpes. And you see all the lesions of the herpes lesions are on the left side of the buttocks. You're not seeing hardly any that are crossing over to the other side. So this was herpes zoster in a person with Crohn's disease. And it was initially called the deep tissue pressure injury. Other etiologies, this is one of the etiologies that you saw on that first slide. This was COVID skin in 2020. We were having so many COVID skin manifestations. I worked for about almost 2 years on the COVID skin manifestations, and no one in the world knows how many there were. The American Dermatology Association started a place where we could put all of these photographs of these COVID skin manifestations, and that's what this is. When the coagulopathy hits from the cytokine storm, because the virus infection, you get the cytokine storm, then you get coagulopathy issues. They're throwing all these clots. Some of them are larger, some of them are microscopic. These are microscopic clots that clot the microscopic clots that go into the capillary region that's going to the skin. And so this top layer of the skin has been has not had enough oxygen, and so the skin is coming off on the top. And here's your dermal layer right here. Look at this butterfly shape. I called Karen Lou Kennedy after we had several of these come into our practice. I called Karen Lou Kennedy of the Kennedy Terminal Ulcer, and I said, Karen Lou, I'm seeing some things that are from COVID, but dadgummit, it looks like a Kennedy Terminal Ulcer that hadn't gone quite as deep. And what we're finding is there's some similarities between the Kennedy Terminal Ulcer and what happened during COVID. Still trying to figure that one out too. This is calciphylaxis. Calciphylaxis, you see calciphylaxis more often in a population that has diabetes and is on dialysis. You start getting these wonky wounds like this with this eschar that start coming up on different parts of the body. Most of the time it starts on the legs, but calciphylaxis can take place any place. That can happen any place on the body. And so this is on the back. It was first called unstageable pressure injury, but that's not what it is. It's calciphylaxis, which is an inflammatory process that we don't understand either. And then this, we don't know which necrotizing fasciitis disease this is, or which necrotizing soft tissue infection this is, which bacteria it is, but this may be mistaken for a deep tissue pressure injury. Here's a warfarin-induced skin necrosis that somebody might call as a pressure injury. And over the on the right is a regular bruise that from a fall. And it's very obvious that that's what it is. But if you don't know better, you might call it a pressure injury, particularly if that person has been on the floor for a while. So again, coming back to this, here is, and somebody said this, here's our moisture-associated skin damage, which is superficial. Here's our deep tissue pressure injury, which is, of course, from pressure at the bone-muscle interface. Here is a Kennedy terminal ulcer, which has to do with all of the organs, or not all of the organs, some of the organs, and it will end up being all the organs when they all shut down. This person is in multi-organ failure, which is what takes place when we have a Kennedy terminal ulcer or skin failure. The person is going into organ failure, and the largest organ of the body, the skin, fails in tandem as the other organs start their organ crosstalk. Kidney, I don't feel good. Liver, you don't feel good. I don't feel good. Heart, oh boy, you guys don't feel good. I don't feel good either. It's called organ crosstalk. They start talking to each other and they start making each other sick. So organ crosstalk, that's a Kennedy terminal ulcer skin failure situation. Here is your chronic tissue injury, which is superficial. And you'll have, if you have erosion, it'll be superficial erosion. And then here is another COVID skin manifestation. So these were 5 different etiologies, all on the same location. And this is over here on the right, the middle one, a photograph. This is one of the photographs that I just showed you. And what the NPIP is trying to show you is say, is this a deep tissue pressure injury, or is it an imposter? Or is it an imposter? And a lot of these are pressure injury imposters. They correlated it to DTPI. But take a look at this when you get this. It's meaningful. And then skin failure. This was an article by Dr. Jeffrey Levine, a gentleman, a physician that I respect a lot. And he wrote this article on skin failure. So you're going to get this one also. And it talks about acute, chronic, and end-stage skin failure. And this is a very common pressure injury imposter skin failure is. So here's the Kennedy terminal ulcer. The Kennedy terminal ulcer, we started learning about this in, well, it came out in the 1800s, not as the Kennedy terminal ulcer, but as decubitus acutus and acubitus alminosus by Dr. Charcot. He first identified this in the mid-late 1800s. So the Kennedy terminal ulcer may appear like a pressure ulcer injury or a chronic tissue injury, and this is associated with organ failure. 2 or more organs in failure, then the skin is going to be compromised also. So nurses, providers, therapists, know which organs are in failure. It's important you get those ICD-10 codes. So when you want to call something a Kennedy terminal ulcer or skin failure, you have the documentation that supports organ failure. Don't run to my clinician, my physician, my nurse practitioner, physician assistant, and say, Dr. So-and-so, would you fill this out as because this was unavoidable. We couldn't stop this. Well, if you don't have all the criteria that creates unavoidability and have all of your pressure injury prevention task in place, you can't call it unavoidable. We have unavoidable skin failure. We have skin failure when there is multi-organ failure. Skin failure does not happen without other organs failing also. So when we look at the Kennedy terminal ulcer, the person is usually in the dying process. The dying process, when people go right into the dying process, within 10 days to 2 weeks, oftentimes you'll get end of life skin failure. Within 10 days to 2 weeks, which is what the time that it takes many organs to go through their full organ crosstalk and full failure. And you've seen this in your clinical practice. The person that's in this dying process, they may die in hours, weeks, or months, but it's still a Kennedy terminal ulcer. These wounds will marcate in a short period of time, usually days, and they can be superficial or deep, whereas that chronic tissue injury may continue for months. In the MDS 3.0, it says skin changes at the end of life, which is scale. Skin changes at life's end, also referred to as the Kennedy terminal ulcer, and skin failure are not, see, MDS over here, top left, MDS section M. I need to bring this up to the 2025, but it still says the same thing. This is when it was put in our document. So we're going on over 2 years now that we've had this statement, and I hope you've taken it to heart and figured out what you're going to do about it, which you haven't figured out because nobody knows what to do about it. Skin changes at the end of life, also referred to as Kennedy terminal ulcer and skin failure, are not primarily caused by pressure and are not coded in section M. Woo woo, yay! Thank you, CMS. Oh, no, thank you, CMS. It's not coded in section M. So how do I report it? Well, you can't. You don't have an ICD-10 code. We have no idea how many pressure injuries we have. We have no idea how many pressure injuries and imposters we have. Our data is all messed up. It is what it is. We're trying to work with CMS on that too. So here is a person that's in the process of dying. They are quite ill. They're in the process of dying, and this is what their skin is doing. And this is a coagulopathy issue. Look at that black skin right there. They do have, this is a dark-skinned individual, and they have that, they're throwing small clots, which might be what's happening with the Kennedy terminal ulcer in that area. And then here's the person 8 days later. Here's the person 15 days later. Here they are 30 days later. And then right after this, they passed. So they were in the process of dying, and this skin manifestation came up, and we have no place to put it in the MDS. We have no way to report it because you don't have an ICD-10 code. So we're working, there's a group of us, we've been working now for 2 years to try to get us an ICD-10 code. So this wound etiology is related to skin failure and not to, it's related to skin failure due to multi-organ failure and not associated with pressure forces. Differentiating pressure ulcer from other similar looking etiologies. So pressure ulcer injury. Let's talk about a pressure ulcer injury. To have a pressure ulcer, which CMS calls a pressure ulcer an open wound. Ulcer is an open wound. Injury is a closed wound, pressure injury. So pressure injury, according to CMS, is a stage 1 pressure injury and a deep tissue pressure injury. Those are intact. That's a pressure injury. A pressure ulcer is open. That's CMS's take on this. So that's why I say, and this is the exact way that they write it in the State Operations Manual, PUPI. So your pressure ulcer injury refers to localized damage to the skin and underlying soft tissue, usually over a bony prominence, are related to a medical or other device. And a pressure injury, here it is, presents as intact skin. A pressure ulcer presents as an open ulcer, and the injury is a result of intense and or prolonged pressure or pressure in combination with shear. Pressure, 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 pressure. Pressure has to be present for it to be a pressure injury. And then it talks about the tolerance of soft tissue, which is different for every person. Every single person has a different, what's called tissue tolerance. Here is, so why does pressure cause pressure injuries? Pressure injuries are bottom-up injuries. It's a perpendicular force that's exerted on the surface of the skin, and the forces go all the way through the skin, down to the bony prominence, usually. It damages the skin and underlying tissue. It compresses the arteries, the veins, the capillaries, usually between the chair surface and the bony prominences if they're sitting, or the bed if they're laying down, which is going to limit the blood flow. It's going to limit oxygen and nutrients and deliver to the tissue. These pressure forces are going to distort and deform the soft tissue and the associated cells. So one of the first things you see with the pressure injury, actually you don't see it. One of the first things that happens with the pressure injury is there is inflammation, and there's literally a tool out now called the Provisio that can tell you if you have a brand new pressure injury that you can't even see yet. And you do this Provisio on the sacrum and the heels every day to see if your bedbound or immobile patients are beginning to get a pressure injury before you can ever see it. So we do have a tool for that. And the buildings say, oh, that costs too much. I promise you that pressure injury costs you way more than that Provisio device. Provizio, I think is how you spell it. So when we look at the pressure forces, we're going to have decreased blood flow, which also limits the elimination of these byproducts. When they break down, these cells break down, they cause inflammation, local inflammation. That's why, and edema. And that's what the Provisio measures, by the way. It's subepidermal moisture, and it measures the edema from the cells that have been damaged before you even begin to see what's happening on the skin. So tissue damage with high pressure applied for short periods or low pressure for long periods will cause a pressure injury. And this is what I was just talking about, the subepidermal moisture that measure the inflammatory edema under the skin. That's one of the things, and you can identify it 5 days earlier. 5 days earlier than your visual. Imagine what this is going to do for you with dark-skinned individuals. Even with light-skinned individuals, when this first starts, you're not going to see it for the first few days. And with dark-skinned individuals, sometimes we don't see it because we don't have the lighting, or it's really so difficult to see. The edema, the erythema is difficult to see. So what's important about the Provisio, regardless of the skin tone, you can see it will pick up the edema from the damaged cells. And this is what it looks like. Shear forces. Pressure and shear create the worst pressure injuries. And when you have your shear, you also have collapse of arteries and veins due to distortion of the tissues. And again, that limits the oxygen and nutrients, eliminates the cellular byproducts, limits the elimination of those cellular byproducts that cause that inflammation. And then when the skin exhibits poor mechanical properties, think about our populations, our older populations specifically. They all have poor mechanical properties of the skin. Then it's going to disrupt the skin layers. So think our older, fragile skin. So shear is a factor in situations where the head of the bed is elevated greater than 30 degrees and that person slides down. They say they get a sacral pressure injury. They almost always, you see the shear forces because you have undermining at the top of that sacrum. How often have you seen undermining at the top of that sacral wound? That comes from the shearing that takes place between the layers of skin when you bring the head of the bed up and that person slides down, the skin sticks, and the underlying tissues shear. And that's what this is showing you here. And that's a lateral force, not a perpendicular force. Moisture, when you have moisture plus heat, that's called microclimate. Moisture plus heat is called microclimate. Moisture is important to control as best you can. That relative humidity, when the skin gets moist, moisture plus skin temperature equals microclimate. When the skin gets moist and then that person's laying there and it gets hot, the heat collects when we're laying on top of this bed or wherever we happen to be laying, sitting in the chair, the heat collects. We have moisture plus heat. The collagen fibers get weaker and they're easier to break down. So moisture plus heat makes the skin more vulnerable. And then you add aging changes on top of that. You know, we're between a rock and a hard place. It's almost impossible to prevent even some of these pressure injuries. It's almost impossible to prevent them. So with increased metabolic rate, the cells have increased demand for nutrients and oxygen as well as elimination, and it's not happening. So all of this reduces the skin's mechanical properties, the stretch, the recoil, and the resistance to tearing, putting them at higher risk for pressure injuries. Friction is a top-down injury. This is not a stage 2 pressure injury. This is moisture-associated skin damage with erosion and the rolling of the skin when the person was pulled or moved over the top surface of the bed. So this is a friction injury. This is not a pressure injury. Friction plus MASD. Sometimes you see blisters. This is friction is repetitive rubbing of the skin. The epidermis is damaged, and that makes the underlying tissue more susceptible to trauma and infections. So the barrier function is disturbed, and so that's going to put that person at higher risk for problems. So friction is a problem, but it's not the main issue for pressure injuries. It can contribute to. So CMS says, regardless of any resident's total risk score when you're doing your Braden or plus your other interventions, you don't just your other assessment criteria. You don't just look at the Braden. If you only look at the Braden, the 6 things for which nursing was taught by Dr. Barbara Braden that they can do to intervene, 6 things. That's your 6 subsets. If you only do those 6 things, your pressure injury prevention program, your assessment process has already failed. There's over 100 risk factors. So you can't just do those 6, nurses, or your pressure injury prevention program has already failed. So regardless of that person's total risk score, on an assessment tool such as the Braden or the Gosnell, whatever you might use, clinicians are responsible for evaluating each existing and potential risk factor for the developing pressure injury, for the development of a pressure injury, and determine that resident's overall risk. It is acceptable if the clinician's assessment, this is so important to you, it is acceptable if the clinician's assessment places the resident at a higher risk level than the overall score. If you're only using the Braden, most of your Bradens look too good to be true for preventing pressure injuries. If the assessment of other factors that contribute to pressure injuries put that person at a overall higher risk factor than that tool, then documentation of the clinical decision, the clinician's decision, should place that in the medical record. So your score, say your score on the Braden puts them at a low risk, but they have congestive heart failure. They have stage 3 chronic kidney disease. So there's 2 organs right there. They are at higher risk. That moderate risk that you may have come up with on that score isn't moderate. It's high risk based on the comorbidities. And that's where the Braden is failing you, because you didn't look at Dr. Braden's original document. She has original documents that talks about this. So you have to look at everything, not just the 6 things that Dr. Braden gave you. You want to differentiate your pressure ulcer etiology from imposters. You want to ensure that your team is competent in performing a comprehensive risk assessment. We have to look at all risk factors beyond the Braden. You want to review mobility impairments. There are no pressure injuries without pressure forces in the immediate area. And immobility is one of the big criteria for you having a pressure injury. What caused the immobility in the first place, and how immobile are you? And your PTs and even OTs, the rehab team, should be helping you with that. You want to consider every risk factor, every organ, every comorbidity, all the conditions that threaten the skin from the inside and out to help you determine what this lesion is. Is it from pressure? Is it an unavoidable pressure ulcer injury that meets CMS's regulatory guidance? Is it an end-of-life, multi-organ failure, skin failure lesion, terminal tissue failure from peripheral arterial disease, for instance? Or is it a Kennedy terminal ulcer because of multi-organ failure? Is it another etiology such as venous insufficiency, arterial insufficiency, inflammation, autoimmune, or other atypical etiologies? There are hundreds of wound etiologies. We have 5 major etiologies, but when you get into dermatology, which causes wounds also, we have many, many, many etiologies for skin issues. So the surveyors, the CMS recognizes the unavoidable pressure ulcer known as the Kennedy terminal ulcer and skin failure. To call a pressure ulcer injury unavoidable, if you're going to call this thing unavoidable, if it's true of pressure ulcer, there is a form of a true unavoidable pressure injury. I might go into that in our next talk. The next talk is about, I think it's the unavoidable pressure injury or the skin failure. So to call a pressure ulcer injury unavoidable requires that you have your care plan in place. You have to have every risk factor care plan for every pressure injury risk factor that you have found. And if all of that has been done, everything is in place, repositioning has been done, nutrition has been done, your CNAs are savvy, they know what they're doing, then you can call it unavoidable. But you have to have all of that information. And I'm not sure, it'll be next time, I guess next month, when we'll do a true unavoidable pressure injury that I'll show you. So identifying the resident at risk for a facility-acquired pressure injury starts with the body systems. You have to look at all the body systems. There are 11 systems. There are 11 body systems. And they all have, cardiovascular, lungs, said heart, brain, lymphatic system, all of the systems, every single system affects the skin. This is our F686. When you first get into it, it says it's your skin integrity tag for pressure ulcers. And this is your basic charge. Based on the comprehensive assessment of a resident, the facility must ensure that a resident receives care consistent with the professional standards of practice to prevent pressure ulcers, and that person does not develop a pressure ulcer unless the individual's clinical condition demonstrates they were unavoidable. So that goes beyond the Braden. The Braden is a fraction of what you need to know for unavoidability. It goes on to say a resident with pressure ulcer, they receive the necessary treatment and services consistent with the professional standards of practice to promote healing, prevent infection, and prevent new ulcers from developing. So this is our basic charge from CMS. Also, it talks to us about routine or basic care and says it's includes, but is not limited to redistributing the pressure, doing your offloading, protecting the heels, floating the heels 24/7. There should be no heel pressure injuries. If there's heel pressure injuries, that means those heels are on the bed. They're not floating. You want to minimize exposure to moisture and keep the skin clean. Again, CNA is doing this. Repositioning, CNA is doing this. Who's cleaning the fecal? I clean fecal. I'm a physical therapist. If there's fecal in my way, I'm not running to the nurses. I'm not running to the CNA to say, oh, clean them, clean them. I can't do my PT until they're clean. I'll clean them, but they got to be clean. You've got to get all that fecal enzymes off of them. If you leave behind any fecal enzymes, if that person urinates, it reactivates the fecal enzymes and causes them more skin issues. So it's very important that we have surfactants that get all of the feces enzymes off of the skin. You want to provide appropriate pressure redistribution and support surfaces and know how to use them. Understand immersion and envelopment and use your devices correctly. Non-irritating linens, and we've already talked about this a bit, I think. Maintain and improve nutrition and hydration where feasible. CMS says where feasible. They get this. Adverse drug reactions, it talks a little bit about that. If they have drugs that are causing lethargy or anorexia, that can become a problem. Also, when we come to trying to get our wounds to heal. And these interventions should be incorporated into the plan of care and revised as the condition of the resident indicates. So the physiology of pressure injury, contributing factors, mobility, pressure, shear, friction, microclimate, which is that moisture plus temperature, plus the airflow next to the skin. Some of the beds are low air loss beds. That's what they're dealing with. Microclimate. The problem is if you have a wound and you have a low air loss bed, sometimes they dry out the wound. So we have to be careful with that. And then the body habitus. Do they have a low BMI? And we don't use BMI all that much anymore to help us with nutrition, but this is how it was written in some of the literature. So a low BMI, skinny mini, skinny. Oh, they're so skinny. They're so light. They're never going to get a pressure injury. Those are the ones that get the worst, the first, the fastest, and the hardest to heal are your skinny minis. They have hardly any subcutaneous tissue. It's muscle and bone. So they are at the highest risk. Remember this, your skinnies are at the highest risk. If your root cause analysis and the wound etiology does not have these specific issues, then the lesion, whether skin intact, partial thickness, or full thickness, is probably not a pressure ulcer injury if they don't have some of these issues going on. Mobility after comorbidities, assessing accurately. After comorbidities, assessing accurately for mobility impairments and implementing a mobility plan of care is one of the most important components of a pressure injury prevention program. Does that person have bed mobility? Can they roll side to side? And when they're on the side, can they hold it? Or are they so weak they roll back? Can they scoot themselves up in bed when you bring the head of the bed up and then you put the head of the bed back down? They've slid down in the bed. Can they scoot themselves back up? If not, there's a mobility issue. Can they go from lying to sitting? Can they push themselves up to sitting? If you have to cue them, if you have to put a hand on them, they're not independent. They have a mobility issue. Can they go from sit to stand with their assisted device? Are they safe with their walker, with their cane? And if they can get up and move and walk with their walker or their assisted device, they're fine. They have mobility. They just need some help with ambulation. So this is your GG section of the MDS, and our nurses and our CNAs, our nurses and our MDS coordinators are usually filling out this. Your therapist should be involved in this. And the reason is, this is our growing up as therapists, it's all about mobility. Now, it's what we live, breathe, eat, muscle movement, body movement, balance, ambulation, all that stuff. So this comes out of the physical therapy profession and has been put in for all of us to use. Look at mobility comprehensively. And that's what they're trying to tell us here. And then here is how you score it. And you have to go put your hands on your patients to do this. You have to put your hands on your patients and residents to do this correctly. You can't do it from an office. Get your therapist to do this. They know how to do this blindfolded. They should be doing it for you and reporting it to you. But somebody has to put their hands on these people to feel how they do with their mobility. You can't stand in the doorway. You can't just stand at the end of the bed. You have to put them through their paces for you to get the mobility part right. Differentiating pressure ulcers from other skin manifestations, look at the mobility comprehensively and use CMS's guidance for the mobility assessment. And this is it right here. If you're not doing this, your pressure injury prevention program has already failed because you do not understand the level of immobility. So the point is, don't call a skin lesion a pressure ulcer injury when the etiology does not correlate to pressure forces. Review mobility first. Score the mobility impairments correctly on the MDS. Work with rehab to support mobility assessments. Or the nurses and MDS coordinators use the GG scoring directions correctly for scoring the mobility impairments. The number one cause of a pressure injury is immobility. Are you capturing your immobility comprehensively? Immobility is caused by organ system impairments and failures. Immobility is caused by organ system impairments and failures. So oftentimes we're going back to the organs when we have immobility issues. What caused that mobility impairment in the first place? Which organs are out of whack? Try to figure that out. Don't default to a pressure ulcer injury when you don't know the etiology. You don't know the etiology. We have the ability to call something a chronic wound. Just call it a chronic wound until you find out what the exact etiology is. Don't assign pressure if you are suspicious that it's not pressure. Sometimes it takes us a week or so to figure out what's going on, especially if we're having to run vascular studies or dermatology studies. Then we're not going to get that correct etiology immediately. Give yourself some grace. Call it a chronic wound of some type, and then go back and get the right code. Even with wound providers, dermatologists or pathologists helping us, and we do. We have a dermatology group that works with us. We have a wound pathologist, the only one in the country that I know that works with us. And sometimes the diagnoses are still unknown. So again, here is your let's see. This is your unspecified code. Is what this is. Do not default to your pressure ulcer injury diagnosis when the skin manifestation is unknown. We're in closing now. There's a wide variety of etiologies that produce wounds in the vicinity of pressure, shear-prone anatomical locations. Be thorough with your assessments. And I'm going to ask you right now, how many of you think that the assessments, and y'all are over here, that's why I'm looking over here, I'm looking at the chat. How many of you think your assessments are as thorough as they should be? Yes or no? Are your patient and residents assessment, based on what we've gone over here, as comprehensive as they should be? Yes or no? I'm going to keep going. Thank you. I'm seeing no's. Providers and facility nurses should discuss the details of the resident's condition before designating a wound as a pressure ulcer injury if the clinical picture doesn't correlate with that pressure as cause. Once a pressure ulcer injury has been documented as diagnosed and diagnosed in the medical record, that diagnosis is often just left there, regardless of its inaccuracy. So if you think the issue is a chronic tissue injury or skin failure, such as your Kennedy terminal ulcer, and the facility surveyors or nurses or surveyors do not have this information yet, share the materials that we're giving you today. Educate them up. We all have to be educated up. I'm 74 years old, and I've been doing this for over 40 years. I'm still educating up. It never stops. Never. And the last box says accurate pressure ulcer injury risk assessments support accurate diagnosis, documentation, reporting, and treatment, and supports legal efforts on your behalf. Do you have any questions? And thank you, Lee, Ashley, Naomi. No. We're not doing our assessments are not being done. It is collaboratively. It's the nursing assessment, the therapy assessment, the provider assessment, the dietitian assessment, interdisciplinary assessments, and we all come together and talk about what's happening. Put all of your brains together, not just one nurse, not just one provider, put all of your brains together, and you're going to have a much more robust and correct pressure ulcer injury prevention program and recognition of these wound etiologies. So I want to thank you very much. And let's see, what are we doing? Join us next month. Here we are. Oh, end of life wounds. We're going to dig deeper in this. I hope y'all come back next month. We're going to be going deep into the end of life wounds. And that's Thursday, April the 30th. And so we're going to be talking about end of life wounds that can't heal due to organ failure, addressing clinical and regulatory perspectives as we know them today. All right, ladies and gentlemen, take good care. Thank you for your time today, and we'll see you next month.